if you start with where the fistula begins and where it ends, more than 50% of these fistulas will have origin from the right side, and nearly more than 85% of these fistulas would drain into the right side again. Very few fistulas insert into the left side. The most common site of insertion of this fistula is to the RA, RV, and the pulmonary artery. So classification, nothing much has changed. This was Sakakibara classification of 1960s. So this is a recent classification which determined the location of this fistula either in the proximal segment of the coronary artery or distal segment of the coronary artery, which because it has implications on treatment and its ultimate outcomes. So we can classify these fistulas as either proximal or distal. Again, depending upon various other qualities of this fistula, several classifications have been proposed. Only when these fistulas, if they insert into the one of the chambers of the heart, they are called as cameral fistulas. Otherwise, they are labeled as coronary arteriovenous fistulas. So these are all other morphological classification based on the number of fistulae, size of the angiographic sizing of this fistula, and what are the symptoms of this fistula, and also the intrinsic changes that this fistula have. Different sorts of classifications are there. So what would be the tips for closure of these fistulas? Let us start with indications for closure, and then we'll talk about imaging, what is ideal imaging workup. Then we'll talk about a few things about the transcatheter closure, and most importantly, we would also have briefly highlight on the important follow-up aspects of this fistula. So first of all, indications for closure. These fistulas needs to be closed only if they have symptoms of significant left to right shunt, either based on symptoms, echo or cath, or they have significant volume overload. For example, if the fistula is between the aorta and the left ventricle, or aorta and the left atrium, there would not be much signs of left to right shunt, but usually there will be significant volume overload. There can be evidence of coronary insufficiency, especially if the fistulous tract is between a coronary artery and a low pressure chamber. In this case, one may have to bring out these symptoms by either doing a stress test or an angiography test. Or if the physician is worried about potential complications like rupture and thrombosis of this fistula, or intra-aneurysmal platelet accumulation and thrombus formation, then these fistulas needs to be closed. So this is a brief protocol described by the authors about which fistulas needs to be closed. Proximal coronary fistulas is by far more safer to be closed in the cath lab or during the surgery, whereas distal fistulas have their own pros and cons of closure. So unless these patients do have definite benefits of the intervention, they should not be closed and better left alone. Modalities of evaluation: echocardiography, CT scan, invasive angiography, MR angiography are all available. Out of all these investigations, MR angiography is least useful as far as coronary AV malformations are concerned. Echocardiography, of course, is an initial and a very good investigation to assess the size of the fistula, locate the insertion and exit points of these fistulas, and also to plan and probable intervention. Also, it will also give you what are the limitations of the indications. This is very useful, especially in small children. CT scan is definitely an essential step, especially if we are planning for an intervention in these children. So this is an example of one of the echocardiography. In this patient, there is a coronary artery fistula from RCA to right atrium. So as you can see, the origin of the fistula from the aorta is quite large, and as it comes into right atrium, there is a small aneurysmal segment after which there is a drainage into the right atrium. So this is an example of an RCA to right ventricle fistula. Sometimes echocardiography will give you such beautiful pictures. You can see the entire fistulous tract starting from the right coronary artery origin up till its insertion point. So in this case also, we may choose to skip a CT scan for such beautiful anatomic description, but CT scan helps you in planning the intervention well before we enter the cath lab itself. So this is another example where the fistula is between the left coronary artery and into the left ventricle. So this is very, very rare and unusual forms of coronary cameral fistula. Same pictures. So this is a plaques view. It shows the coronary cameral fistula originating from the left coronary artery and having a interventricular course along the interventricular groove and inserting into the apex towards the septum. It also has formed an aneurysm in the septum before it inserts into the left ventricle. CT aortogram is a mandatory investigation before we plan any complex coronary fistula. So this is a protocol for the scans. Most of the times we also do follow the same protocol. Remember, the heart rates in this baby should be brought down to at least around 80. So we may have to give either ivabradine or beta blockers before doing a CT scan in such patients. So once we do that, this is the beautiful pictures that you can get on the CT scan to plan the intervention. So this was a case of right coronary artery to right atrial fistula. So in this 3D reconstruction photographs, you can see there is a huge fistulous tract with multiple aneurysms in between the origin and insertion point of the fistula. You can also see the normal right coronary artery coursing the right AV groove. So bottom pictures show the normal caliber left coronary artery and the circumflex. So this would be the identified potential site of occlusion of this fistula in the cath lab. This much planning can be done on a CT scan. So this is a rare case of left coronary artery to left ventricular fistula. The entire fistulous tract is behind the heart. It's all posterior. So again, this is one of the potential sites for occlusion for us in the cath lab. So this is a VRT reconstruction showing the entire fistulous tract in a 3D orientation. So this case had left coronary artery fistula to the LV but through the interventricular groove. Here again 3D volume reconstruction shows beautiful fistulous tract in between the interventricular groove and the takeoff of left coronary artery and LAD. So this happened to be a distal coronary artery fistula. So this is a potential site for device closure in this patient. Again, more reconstructions and delineation of morphology. So when it comes to procedure planning, most importantly, one has to plan the route of closure. Are you going to retrograde from the aorta, or are you going to form a AV loop or atrioatrial loop to close this? Or are you, and also identify the potential landing zone. Where do you want to land your device, and what would be the size of the device that you have to choose based on the anatomy. Type of the device, whether you want to use a vascular plug or different types of devices. Plan for general hardware, we would cover them, and also assess these patients for the post-deployment problems, if any. So in this picture, again I am using this picture to show the proximal coronary AV malformation and distal coronary AV malformation. In distal coronary AV malformation, you have only one potential site for occlusion. You cannot actually occlude these fistulas proximally because native coronary arteries are originating from the proximal portion. Whereas in proximal coronary artery fistula, potentially there can be two sites of occlusion. But when you have two probable sites of occlusion, the most preferential site of occlusion is the proximal or nearer to the origin of the coronary artery to prevent thrombus formation and progression of the thrombus. Ideally, you have to close both. If a fistula is like this, that means if it has multiple aneurysms inside, if you occlude only the proximal portion of the fistula, you will leave behind a big cul-de-sac without closing the distal opening. It's ideal that you close both the ends in these cases. But many times it may not be possible to close the distal end of the fistula in a complex case. So whether you have to do retrograde Artolan approach or you want to form an AV loop. In this patient, so it is very easy to do a transaortic retrograde approach. As you can see, as the wire goes more distally, there are multiple bends and curves. It is not possible to form an AV loop. So in this case, we chose only to do a proximal occlusion of the fistula. Sometimes even your sheath positioning may be a problem. Then you may have to form a aorto-arterial loop in this patient so that we can position the sheath in a more distal location. These are the device armamentarium that's available for AV fistula device closure. Most commonly, we would prefer a device to be more cylindrical, longer, and it should be available in various sizes to suit a wide variety of length and breadth of the fistulas. For us, the most common device that we use is either AVP2 or off late we have started using Conor MFO device. So in the earlier past, we have also used a few ADO1 devices as well. So about hardware, always have enough long braided sheets, especially if the patient is older. So you need to reach from the femoral artery till the fistula straight. So you need a long braided sheets because these sheets can bend if they are non-braided. So have exchange length hydrophilic guide wires, whether you snare it or not, because these wires are least traumatic. Use compatible cables for the proposed devices. Some of the devices don't come with the cables. So in the cath lab, you should not be looking for cables at the last minute. Have additional access for angiograms. So, for example, if you're doing in fistula from the aorta, always have a plan to have one more access for demonstration of the location of device. But many times we may not be able to do a angiogram through the sheets. Snare catheters have to be had handy. So plan for a septal puncture if the fistula is into the LA or if the fistula is in LV and you're planning to snare the wire out from the LA. Okay, few case examples. This is one simple case, RCA to RA fistula. So this was a fistula tract with this angiogram and simultaneous 3D picture I am showing you, because we usually determine the angle of projection in the cath lab based on the CT scan. So with this CT scan, we know that it's a lateral view that is most suitable. So we have already started this procedure doing it in the lateral view. So this is the placement of the device. And once it is in good position, we have released that device and we have closed this fistula only in the proximal portion. You can see good filling of the right coronary artery, and the right coronary artery takes quite high up compared to the device here. So this was a case which we recently did. Again, the fistula is from the aorta into the LV. So again here we straight away took LEVO view because this was the best projection that we got from the CT. So it was very easy crossing this fistula. So once the fistula is crossed and we have decided the landing zone, we have deployed the device. And once the device is deployed, it's very important that we demonstrate the native flow of the coronary arteries. Sorry, struggling with this. Native flow of the coronary arteries once the occlusion is done. So follow-up, very important. Not all the fistulas have very good outcome. So the outcome is better if the fistula is more proximal, but when the fistula is more distal, so many times there might be suboptimal remodeling results and there could be persistent leaks through this fistula. So it is recommended that these patients have regular follow-up at least once in 3 to 6 months. Sometimes they may need a coronary angiogram to see what's happening to the intervention that we have done, and many of these patients do require either antiplatelets and sometimes anticoagulation. And this is a brief outline of what is ideal in these patients based on author's experience of 42 patients. Thank you very much.